100 newborns. Strikes Caucasians much more frequently than it does Hispanic Americans or African Americans. However, carriers are about 1 in 25. So there are a lot of us. That means there's, statistically speaking, there's a couple of carriers in this room, right? It's autosomal recessive, which means your offspring have a what percent chance? 25. 25% chance that your offspring will have the disease. 50% that they'll be a carrier. 25% that nothing. Okay. About 95% of patients are diagnosed pretty early on in childhood. And about 75% are actually diagnosed by age 2. What do you guys think is the first thing usually that gets noticed? Meconium ileus is about 20%. Salty sweaty, failure to thrive in newborns. Yep, because you have the malabsorption.
This is part of the blood work now, too.
It is. Yep, they screen all newborns now. Okay, you guys know me and my history here. So until fairly recently, most children died before age 5. This was bad stuff. In 1978, Francis Collins, who's now head of the NIH, he was a resident. Believe it or not, he was an internal medicine resident at UNC. Bless you. And they had a 19-year-old, I think she was a nurse there, like a new nurse or something, who was diagnosed. And he got stuck taking care of her and took an interest in it. I don't think he had his PhD yet. I don't remember if he did that later. When I was at the NIH, he was head of human genome. His office was like right around the corner from my lab. And he sings and plays the guitar. And when we'd have these institute picnics, he would make up all these silly songs. So he would take regular songs and then make them into genetics songs. But everybody's kids loved him. So he was Uncle Francis to everybody who had kids there. Side note, he's also a lay minister. So I think he's really cool. He was an atheist who became a born-again Christian at some point, and is a lay minister, but he's written a couple of really cool books if you're interested. One is called The Language of God, which talks about science and genetics and relation to religion or non-relation to religion. And then another one that is, The Language of the Sequence or something like that. But it's about the Human Genome Project and ethics behind it and stuff. They have him at Barnes & Noble. He's a really cool guy, so they're interesting books if you're interested. Moving on, in 1985, a doctor at the Children's Hospital in Toronto located the CF gene on chromosome 7. Wasn't really known that was CFTR yet, but they knew that that chromosome was there, which was really cool because in 1985, that would have taken years to get through. I mean, there was no sequencing really at that point. They were doing knockouts, they're doing all kinds of crazy stuff, but he found it. And it wasn't until 1990 when the first kind of really beginning wave of gene therapy started that he and Jim Wilson developed a viral vector for CF. Was great in vitro and cells. It worked fabulous in baboons. They put it in humans and it failed miserably. Tried several times. Wilson eventually, I think in '99, had a phase 1 clinical trial for it. And they finally figured out there was almost no way to insert this gene into humans without there being some type of rejection. I don't think they even really figured out why. They tried every which way they could think of, and nothing really worked. So after that, the CF Foundation and research really kind of shifted more towards drugs for this disease. Not really fixing the symptoms, but actually trying to target the bad protein in the cells with the drug. All right, so symptoms that some of you guys have already mentioned. Very salty skin, persistent cough, frequent lung infections, shortness of breath, failure to thrive, gastrointestinal difficulties, male infertility. Usually that's because of the absence of the vas deferens. We'll see that in a second. So it's caused by mutation, and there are several different ones. We're talking variable expressivity here again. So there's different levels of disease. But the gene is located on chromosome 7. For our friends who like to memorize the exact location, you knock yourself out. Go right ahead. We'll give you toothpicks to scatter and count next. But the CFTR gene codes for a protein called cystic fibrosis transmembrane conductance regulator is the CFTR gene. Basically, this is a chloride ion channel, which obviously controls the movement of water in and out of your cells and your tissues, so you get the thick mucus, right? So you don't get the nice, thin, slippery stuff. You get the thick stuff that's going to capture all your bacteria and goodies in there. It also does have a role with functioning of sodium channels. So again, we're still looking at, movement of water. This really affects the lungs and the pancreas too. I just thought this was a pretty cool picture. This is off of a Discover magazine article that I found. There's some really, CF is a pretty well-known disease. There's a lot of really neat information on the web. But, where's my pen? This one here was pretty interesting, especially for patients one day to be able to see, what happens here, what happens with the mucus. Shows the blood of the mucus, so a lot of these patients get hemoptysis. But it also shows how other organs are affected with CF. So I thought it was just a nice little picture. It shows a mucus plug in here. Pretty much if you have a duct, it's going to get plugged, right? Because it's secretions, no matter where, you're going to have problems with thickness. Okay, so we talked about failure to thrive from the malabsorption. So gastrointestinal issues, right? Anything with ducts. So your pancreas can't really secrete enzymes. Your biliary ducts get clogged up. Nothing's getting out. And then of course when it backs up, you wind up getting scar tissue, fibrosis in those tissues. Then eventually it's not just the fact that they're clogged up, they can't really function anymore when they're all scarred off. We talked about frequent pulmonary infections. These patients get kind of the worst of the worst. They get, the aspergillus, they get the fungal pneumonia, they get all that kind of stuff. Hemoptysis, I can't even imagine having a little one and seeing a little one cough up blood. That just can't even go there in my mind. Cor pulmonale, in other words, right-sided heart failure. So isn't really a surprise once you think about it. But these patients eventually get pretty high PA pressures because of all of that backup from the lungs. So you get this backup into the pulmonary arteries. So that pressure starts building up, and eventually you get right-sided heart failure. Pancreatic insufficiency. CFRDM is a CF-related diabetes mellitus. So again, these patients get backup either into the pancreas, so nothing's coming out, or eventually the cells kind of fibrose off, scar off. A lot of times this is a little bit later manifestation of CF, but it can be in childhood. I went to school with, growing up with two kids, brother and sister, who both had CF. I mean, talk about your bad odds. They had 2 kids and both of them had CF. But they both had the CF-related diabetes, and they both got it, I think, about 12 or 13. The brother actually lived till he was 38, which was fairly impressive, but he took really good care of himself. The younger sister, who was my age, I think she passed away at 25, but she smoked, she drank, she decided she had this and was gonna go, she was just gonna live life. So, it was really tough on her parents, but that was the decision she made. So, it's a difficult disease. Meconium ileus in newborns, like you mentioned. So, obviously meconium is that fresh poop in babies, right? The first couple of weeks. Well, if they get an ileus and you get blocked up, that's a pretty good tip-off. I think that happens about 20% of newborns with CF. So that would be a pretty big first sign. You know, it's going to happen the first couple weeks of life. And then again, male infertility, the CBAVD, which is the congenital bilateral absence of vas deferens. I would think things like this might be something good to study for your final. Okay. All right. May need help here for a second. I want to put this into. I know. You want this one? Yeah. So this is from the CF Foundation, and they have grants through Genentech and some other people to do education stuff, a lot of research. Yeah, the first one down there. So this is their, I think he must be their head of research. He looks like he's having a TIA, but he actually gives some really good information. So a couple of takeaways is the information is good, but second of all, if you're ever asked to do one of these videos and you're really horrible on camera, delegate to somebody else. Otherwise, people like us are going to make fun of them. But
have somebody else present it.
Yeah.
Welcome to the Cystic Fibrosis Foundation CF Education Day webcast. CF mutations, nonsense, or stop mutations, such as G542X. This webcast is hosted by the Foundation and supported through an unrestricted educational grant from Genentech. I'm Leslie Hazel, Director of Patient Resources at the Cystic Fibrosis Foundation. To learn more about CF research, genetics, lung health, nutrition, and how to avoid germs in CF, please watch an archived webcast on the Foundation's website. Joining me is Dr. Peter Mogazel, the CF Center Director at the Johns Hopkins CF Care Center in Baltimore, Maryland. He's going to help you understand how this mutation causes cystic fibrosis. Welcome, Peter.
Well, thank you for having me, Leslie. Before we talk about this specific mutation, I'd like to talk to you about how cystic fibrosis affects the body. CFTR is caused by a mutation in the CFTR gene, which encodes for a chloride transporter that sits at the surface of cells. When it's defective, there's abnormal salt and water transport in and out of cells, which affects mucus wherever your body makes mucus. In the lungs, this thick, sticky mucus blocks the small airways and allows bacteria that we all breathe in to become trapped in the airways. This leads to inflammation and airway damage. It also affects the sinuses, where that same mucus leads to recurrent infections. In the sweat duct, sodium and chloride are not reabsorbed, so that the amount of salt in the sweat is elevated. And this is used as a diagnostic test for cystic fibrosis. The GI tract, comprised of pancreas, intestines, and liver, are also affected in CF. About 80% of patients with cystic fibrosis will have pancreatic insufficiency because the small ducts in the pancreas are blocked and destroyed, and pancreatic enzymes are not produced to digest food. Severe liver disease can occur in a small percentage of patients with cystic fibrosis as well. Finally, there can be male infertility. This is caused by absence of the vas deferens, which is similar to having a vasectomy. Before we go on to talk about the specific mutation, I'd like to focus on the lungs in a little bit more depth. I have a video to show you which has what we call mucociliary clearance, which is clearance of the mucus out of the airway by cilia that line the surface epithelium. Here you see the normal airway with normal cells eating and moving mucus out of the airway. Now in the cystic fibrosis airway, the mucus is thick and sticky and actually smushes the airway epithelial cell in the cilia. This is caused by abnormal chloride transport, which is shown here in CFTR in yellow, which isn't transporting any chloride, and excessive sodium reabsorption, which is shown here in green. This is the problem in the airway that leads to airway inflammation, infection, and damage.
Peter, what is a nonsense or stop mutation in CF?
A nonsense mutation is one where no protein is produced. I have a video that will help explain that. What you'll see here is a RNA molecule. And sitting on the RNA molecule, shown here in yellow, is a ribosome, that blue and red ball in the middle. It moves down the RNA to make the protein. And that's what you'll see coming out at you as we move forward. As it moves forward, though, instead of being a normal code, there'll be a stop codon shown here in red. When the ribosome hits that, it stops and breaks apart. No protein is made, and the RNA is degraded early. In this case, no protein is made, and therefore that's what causes cystic fibrosis. One could imagine a therapy where a drug could bind to the ribosome and allow it to read through that stop codon and make a full-length protein. Rick, can you show the next video which illustrates that? You'll see the same RNA and ribosome. Here, once it moves forward and hits the stop, it's activated by a new drug. Rick, can you go ahead and start this? So here the protein is being made, it hits the stop. Now a drug comes which activates it and allows it to read through the stop codon. A protein is made and gets to the cell surface and will function to transport chloride and regulate sodium transport. Leslie, I hope this has been helpful in explaining this mutation.
Thank you, Peter. Very much appreciate trying to help the community understand this mutation. I encourage you to talk with your CF Care Center to learn what your or your child's mutations are. You can learn more about CF research and the drug development for
So, however, the illustrations with the cilia try to move and the sticky mucus on top and then the ribosomes and all that, I thought that was pretty good. So it was worth a little bit. All right, how do I close this out?
mutations on the Foundation's website.
You can just go. We don't need to see her more. She's almost scary. No, I'll save you guys. We have more later on, but I'll save you from this one. Okay. So, but those are pretty, I thought those were pretty big explanations. I could stand up here and said it too, but maybe he had too much Xanax, I don't know. But anyway, I think these, yes ma'am, question.
Well, I was just gonna ask, people with CF, are they like hypersensitive or allergies? Because one of my friends has it, and everything has to be like really specific, like the bedding, because she lives right next door, and like her 3 roommates had to get like this special type of bedding because for the other bedding, like the normal one, she would have all these like really long like cough attacks, and she wouldn't be able to be in the room.
Right.
So I don't know what.
Well, probably anything that reacts with the airways will be difficult for them. So yeah, allergens, dust mites, I think anything that would, for you and I, if we get allergies, right, we kind of get the back up, we get the extra mucus, but we get nice, thin, watery mucus that we can blow out or cough up. If they get any extra mucus production for any reason, it's going to be thick and tough. So yeah, that doesn't surprise me.
She was really active too.
Pardon?
I mean, she was really active. Like she was like on the dance team.
Oh, that's great.
Yeah, she like did all this stuff and it never got in her way. But every night she would have like these like really bad coughing episodes, and you would know like it was her.
Yeah.
From that.
So that Discover magazine article, which I have listed at the end on your resources, it has great stories about two sisters as well, and they're very active and stuff too. But they talk about at night is really when they have the issues and stuff like that. And I know, you know, other kids, like their parents at night have to do the percussions and stuff on their backs to loosen everything, but, which, you know, I don't know why, but even when any of us gets a cold, when does it always seem to be worse? At night, you know, and God forbid we try to lay down and everything hangs in there and we cough and everything seems to happen at night. But was there another question over here? Okay. You guys just want me to move along. It's Friday. Okay, so I really like this little picture. It's very, I know it's very simple, but I like, you know, KISS, keep it simple, stupid. Just makes more sense, right? So this one shows a nice normal, healthy lung cell. You've got these chloride ions. The CFTR protein is made, number one. It's in the right location, number two. And three, it's functioning. So those are three real big ways how CFTR might relate to the actual disease of cystic fibrosis, right? Nonsense mutation, like the guy said, we are not getting protein at all, or the protein doesn't get to the right location. It can't actually get to the cell membrane for whatever reason. Or three, it might get to the cell membrane and not work. 3 ways. Okay, so the first one you see, everything's working nice. Normally, chloride ions go back and forth. We're good to go. That keeps the mucus thin, keeps it from sticking to the cilia. All the germs get swept out. The second little picture is when it's a function problem. So the protein's made, it's gotten to the cell membrane, but it's not functioning. It's not letting those ions move. And the third one is you can get location and function issues. Because if it's not getting to the right location, it can't function, right? But generally, in my world, that's a location issue. Because it's not even getting to where it's supposed to be. All of those create the exact same problem, though. Okay, so some of the treatments. Well, there's variable expressivity, so you're getting variable symptoms. Okay, so some people, there's a little bit made, or it functions a little bit, some of it functions, not all of it functions. It depends from person to person. But typically, what patients go through is nightly or daily airway clearance. So where they're manually, with percussion, you know, parents beating on the kids' backs every night. They also have these vibrating vests out now that can be worn. That would be pretty cool. Bronchodilators, keep the airways open, keep things moving. And these patients are also going to take pancreatic enzyme supplements and replacements. Because otherwise they're not going to digest anything, right? Everything's getting backed up, built up. Whenever I think of these vibrating vests, I always think about the little baby chairs, the infant chairs that, you know, swing and vibrate. And I was terrified to put my baby in with the vibration on. Because when you think about it, if you sit even like a vibrating massage chair, you know, your eyes kind of squiggle, and I was terrified with the first one that, like, well, I'm gonna like shake all of his neural components loose, and he's gonna have double vision and stuff for the rest of his life. And pediatrician assured me that doesn't actually happen, but I was concerned. And of course, you know, if these patients have diabetes, they're going to be on insulin. They're often on antibiotics for infections. I mean, this is kind of, these three right here are kind of no matter what, these patients are going through this. Okay, so we've talked about the fact that they tried gene therapy in these patients, and it failed, unfortunately. Who knows what Jim Wilson is also famous for? Famous for a couple of things with gene therapy. Okay, so he was the one who, the kid who died, Jesse, gosh, what was his name? He was the very first gene therapy patient tried in the United States. And he got an adenovirus to deliver something. I don't remember, it may have been for CF. But anyway, he died. So that was Jim. And then Jim's also known for being the guy who decided for a while he was going to try to use Ebola as a vector, as a viral vector. Yeah, we used to steer clear of him when we were at gene therapy meetings. Yeah, he was just, you always just wondered what he was walking around holding in his pockets. I mean, who in their right minds thinks, oh, let's play around with Ebola, because, you know, if that recombines the lab, that won't be an issue at all. He's at Penn, so just be wary if you ever wind up at Penn for work. But so the last thing we're talking about now are the drugs that are out are called these CFTR modulators. And it was really kind of hard for me to explain, so I'm going to show you a couple more videos. I think I got it this time.
Is this a video we're going to cry? I like the ones when we cry.
You like them when we cry?
No.
No. No. No, this one is a, it's going to be another cartoon. Oops. All right. You guys are going to be so proud and cheer for me if I actually get this right. Ha 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 ha. Alright, this one may be similar to the one we saw, but it's still, I think it's pretty cool. So this is just showing the chloride ions moving in and out of the channels. And that's what happens if it gets blocked. So right, this location is correct, it's not functioning. And the Ghostbusters mucus lays on top of it. And then this is how one of the new drugs for the CFTR modulators works. So it's not working, this drug comes and binds to it, and it somehow changes the composition or the shape of it and allows it to work. Yeah, so pretty cool. So obviously they did a lot of really cool protein sequencing and computer modeling to figure out the shape and exactly what wasn't working. Those are some really cool protein chemists that do that I would never ever have the patients to be in my life, but they do really, really neat stuff. So those are the drugs out there. There's like I think the names are in your book, Caldexa or
Bloody.
that one. All right. Oops. No, I want the end of it. Oops. Okay. And these are your resources. So, it's Friday. We're all ready to go to happy hour. Questions?
Yeah. So weary.
No questions.